So first, can you introduce yourself and tell us where you're from?
So my name is J.Brown. I'm the medical director for the San Francisco Emergency Medical Services Agency, and I'm from San Francisco, California.
As I know, it's not your first time in Lithuania.
Yes, that is true.
So how do you like it here?
I enjoy it very much. I've lost count of how many visits. This is maybe 9 or 10, I'm not sure. But I started coming in, I believe it was 1998, but I started in Vilnius and then came to Kaunas. I was talking with Nedis and Paulus, we think it was 2003, to help establish some training around cardiac and pediatric emergencies. So it's been very interesting to see all the changes from the late 1990s to the present time.
And maybe you remember your personal first shift as an ER resident?
It's a very good question. I remember, no, I don't remember my first shift, but I remember the moment I decided that I wanted to work in emergency medicine. So I started my training as a general surgery resident. So I went through medical school on a scholarship from the Navy. And in the Navy, in the military, our first year is spent as interns rotating to many different services. So we could select surgery as an emphasis, or medicine, pediatrics. But I decided on surgery because I thought I liked to do procedures, I liked to use my hands to treat patients. So my emergency medicine rotation was a required part of this year. Everyone could emphasize one area or another, but they had to do certain rotations, family medicine, pediatrics, intensive care, with the idea that when we finished our first year, we would be general practitioners working for the military in various posts. So I saved my emergency medicine rotation for my last rotation. And the emergency department I worked in was very busy. We saw about 90,000 patients a year. And the staffing we had was 3 doctors, 1 attending doctor, 1 senior doctor, and 2 residents. The 2 residents were interns, first-year residents, and the attending doctor only half the time was trained in emergency medicine. The other half the time was trained in some other specialty. So it was a very, very busy shifts. We did not have a trauma system, so we saw trauma cases as well as medical cases, pediatric cases. And I was on an evening shift. I had several patients. I think I was managing 4 or 5 patients with severe respiratory distress and cardiac chest pain, and then a few minor patients and minor illness or injury patients. And then the triage nurse called me to the front and said, there is a patient that we think has a psychiatric problem, but we're not sure. Can you please interview the patient and help decide whether they need to be seen in our emergency department, or we could send them to the psychiatry department. So I was sitting in the triage area, which was a very narrow room, and I knew from my training that I should not block the patient inside the room, because if the patient panicked and felt they need to leave, they would, run me over to leave the room. So I was inside the room, and then the patient was in the middle, and the patient's wife was on the outside the room with the triage nurse waiting for the decision. And I was interviewing the patient, and the wife was trying to communicate with me using sign language about things that the patient was saying that were not true, that were false, kind of things like this, And so I was thinking, this is amazing. I'm taking care of 5 very sick people, a few people that are having minor problems but are dependent on my care, and now I'm trying to solve the puzzle of what is going on with this patient and why are they here and what do they need, And I thought, this is the specialty for me. So when I finished that shift, I went to my director and I said, when I finish my year of or time as a general practitioner, I want to come back and do emergency medicine. How do I do this? So he helped me to then, plan going forward. And what was interesting is just the next day, the surgery department offered me an exemption to say, well, if you stay with us, we have an opening, we like you, we want you to work with us. So you won't have to do your general practice. You can go right into surgery. And I thought, interesting, if they'd made that offer 2 weeks before, maybe I would have taken it. But after that experience, I decided, no, this is what I really want to do. So when I came back, I had spent a few years as a general practitioner, and I had several emergency experiences. I was deployed on ships and with the Marines, with the American fighting force. So I think I was, ready to start my residency. And when I came back, we were in the old facility, the hospital that we had used for many years, but with a new staffing. So now we had emergency physician attendings, and the residency program had started, I think, a year before. So we had some senior residents to guide us as junior residents. So I don't remember that specific shift. I remember the shift I remember most explicitly about my residency was the day we moved to the new hospital. So we had an opportunity to go from an older hospital to a new facility, and I was on the night shift, and the move was made in the very early morning hours. So the night shift stayed over, the day shift came on, and all of the residents in the rest of the specialties were moving patients, so they gave their pagers to me. So I had pagers all across my belt, and then I had pagers like a bandolier, like a Mexican bandit would have going across their chest. And I thought, I hope they don't all go off at the same time, because I'm not going to be able to decide which one is ringing. And during the transfer, everything went smoothly, and it was very, good luck that the last patient we took care of in the old Naval Hospital Emergency Department was a drunk sailor. And the first patient we took care of in the new emergency department in the Naval Hospital was a drunk sailor. So different drunk sailors, but one continuity from one to the other. I thought that was very ironic. So, but that was another shift that stuck very much in my head in my early career.
What do you think? What kind of qualities, personal qualities, an emergency medicine resident must have? Mm-hmm. Like maybe 3 qualities or?
Sure, I think it's a little bit difficult to choose, right? Because there are many. I would say one of them is the ability to enjoy their life at any stage that they are at or living. And let me illustrate that with an example. When I was a medical student, my first year of medical school, I was in a course that involved learning how to do histories from patients and do physical exams on patients. So every week or 2 weeks I went to the hospital, and I worked with a mentor and would interview a patient, and they would critique me and so on. So I was at the hospital one day, and I after this training, and I went to the cafeteria, and I encountered a friend who was my supervisor when I worked at a summer camp for children. And very nice man, had not seen him in many years, so we had a good reunion over supper. And he was doing his family medicine residency. He was, I think, a 2nd or 3rd year, so very far along. And I was complaining to him, saying, as a medical student, there's so much work, we have to classes on Saturday, I'm having to learn as much material as I learned in 4 years in college and my first 2 years of medical school. And he said something to me that I'll never forget. He said, well, I, as a resident, look at my time in medical school the way you, as a medical student, looked at your time in college. I was saying, I had so much more free time in college, I was able to do more reading, I was able to do things with my friends, and so on. And he said, if you wait for some, future point that you can't imagine, like when I finish my training, when I'm working as an attending, when I get a professorship, whatever it might be, you will miss too much of your life going along the way. So he said, you need to find a way to enjoy what you're doing now. And I thought that's really good advice for me. So I started to work with a youth group to do outings, camping kinds of things, only maybe once a month or once every other month, but it was a way to say, I am going to do this for myself, something healthy, something to look forward to every few weeks. So, and then from there, built things like that into my residency, my fellowship, my time as an attending physician. So I think the quality is the ability to give 100% in the work, but have time or have part of life that is nurturing and is going to sustain what we call longevity. And I think that that's been very, very important. I think a second thing that has really helped me for quality is, and this is not exactly a personal quality, maybe it's more of an intellectual quality, of staying curious and being able to focus that curiosity onto an area of the specialty where I can really learn a great deal. So we think of emergency medicine as learning a little bit about a lot of things. So when I trained, we said the first 30 minutes of any disease that we need to know how to treat, recognize and treat. Now we think of it as any 30 minutes of any disease, because we see so many patients that have chronic care issues or primary care issues and things, so it's not just the first 30 minutes. But I think that doesn't allow me the satisfaction of really learning an area and feeling I'm a master of that area. So for my own curiosity, I think it was important to find an area. For me, it was EMS and disaster medicine. I think for many others, it's areas within emergency medicine, knowledge base like cardiology, ultrasound, pediatrics, etc. But I think having that area within the specialty of real mastery has kept my curiosity fed, and it's a little bit more reasonable than trying to do that for every single thing that emergency medicine covers. So I think curiosity would be my second thing. And then I think the third thing is to be a good friend, participant, and team member for the people that I work with. So sometimes I get distracted because I'm concerned about something, anxious about something, trying to focus on a process or a level of care, and then I ignore the people around me or I shut them out. And I think that's a bad situation. It happens to everyone from time to time, but I think some people are not attuned to or thinking about considering that a value to do every shift or every day that they are at work. So an example that I use on a practical basis is at the end of every shift, I go to at least a few of the people on the team, junior residents, senior residents, nurses, assistant staff like nursing assistants, and I say thank you for your help, so that I'm aware of their presence and their contribution to taking care of the patients. And when they come to me, I do the best I can. I'm not 100% anywhere near that, but I do the best I can to try and listen to them at the moment and see if I can help with what their issue is. And I think I've tried to extend that beyond the emergency department. That was something that was a gift of becoming an attending from being a resident, was I had the time to step back and see the bigger picture of what was going on in the department besides just my patients. So when a consultant came down, or when I went to the charge nurse to check in to ask for update in what was status of the emergency department, etc., I could pay attention to them. I could say, oh, you look tired. What happened? Are you feeling all right? What happened in this particular case? And then I get some information to satisfy my curiosity, and we can have a discussion about, well, why did you, as a cardiologist or cardiology resident or whatever, decide to do these things? So it's an ability to be a team player that I think enriches my life, but hopefully also makes the other people that are working with me more comfortable and confident, so that when they notice something, they can tell me and make a better solution for the patient or for a problem. And I can tell you many times I have been repaid in that, where someone has said to me, oh, did you consider this thing or that thing? That I think if they didn't consider me to be approachable, they would not have mentioned this. So we tried to bring a little bit of that in our first instruction when we came to Lithuania to talk about resuscitation teams and how we would resuscitate cardiac patients, pediatric patients. The fact that we must ask, even if we are leading, we must ask the team, do you have any other suggestions? Here is what we are planning, let's execute the plan, do you have any other suggestions? So that it doesn't become as the leader you must be absolutely right all the time and we will follow anything you say, whatever happens. Sometimes in the moment that needs to happen, but it's not a good strategy, I think, for good patient care, but also for enjoying life in the emergency department.
And this year is a historical year for emergency medicine because in the US you're like having a 50 years anniversary, and here in Lithuania we're having 5 years anniversary, and just in a few months we're gonna have first emergency physicians. So maybe you have any advice for them, or just saying good luck or something?
Oh yes, so it's good. I would like to add that you're also having the anniversary of 100th year, the centennial of Lithuania, right? So it's a very important and exciting time, and it's an opportunity to think, what do we hope for in the 100 years to come, right? So what will it be like at our bicentennial? What will it be like in 10 years of emergency medicine in Lithuania? What will it be like for us in the States in 100 years of emergency medicine? So I think starting out in a new field is a difficult endeavor. I remember when our first class graduated in 2012, we had many surprises along the way. So one of the surprises, for instance, was we had hired a number of physicians to work on faculty to help strengthen the residency, but then when the residents graduated, there were no openings, so we couldn't hire any of our own graduates, right? So we didn't anticipate that, and we helped them to find jobs in the community and other jobs. But I think that as a first graduating class, it's not exactly the same situation, but the idea that what you plan may not be what happens is an important idea. So I think being flexible as graduates of the first program to say, well, I'm going to plan this, but if it doesn't work out, that's okay, because I will plan or I will find other openings. So I think that flexibility and the willingness to say we're going to innovate, as I mentioned in my talk, innovate by having disaster exercises with stuffed animals, having drills where we do something simple, little pieces of the functional preparation for disaster. So I think having the spirit of innovation to say, I'm going to take this position that I'm now working in as a graduate, and I'm going to develop it in a way that will give value to the patients and to the hospital where I'm working. So I think flexibility, I think innovation, and then I think having the pleasure of the responsibility being the first graduate. So on the one hand, it's a great achievement, and I think the graduates can take a lot of pride in that, and there's responsibility attached with it too, because they are the representatives, of emergency medicine going forward. I think an advantage that Lithuania has in developing this program now is that there have been many other programs that have gone through the process of formation and learned a lot along the way. So there are many, many tools, many resources that the graduates can use for their job and for their life. So they have to invent some things, but they don't have to invent so many things. I think what will be interesting is to see what their unique contribution will be. So every class that comes through and graduates in our program has something unique about it and has left something behind to improve the situation for the next classes. So I think that's my challenge to the graduate class, is to say, what is it that you leave behind, or that you would hope that then your fourth and third and second and first year residents can use to improve their training and their lives. And I don't know what that might be, We have many different examples from things that we have done, but I don't want to suggest them. I think that your graduates should be the ones that decide those things and develop those things. So I of course wish them luck and a longevity of career. I think that's very important, is to also think that I'm going to do things that I will enjoy my life and my career, so that I can have a good practice of emergency medicine, and to plan for that. So.
Thank you very much. It was a pleasure interviewing you.
You're welcome.
Hello.
Good afternoon.
Could you introduce yourself?
My name is Francis Mencl. I'm an emergency physician from the United States.
Most of the Americans don't know such a tiny country as Lithuania, but you fortunately found some time to visit us in this Congress. Could you tell a little bit, how did you find us? What brought you here?
Well, I know many of the other speakers here. I do a lot of traveling. My roots are in Europe. I was born in the United States, but my parents are from what was Czechoslovakia, and my wife is Czech. I also spent 2 years working in Holland, so I actually know where Lithuania is. So,
all right, that's really nice to hear.
I'd never been here before, and this was a wonderful opportunity.
Have you already visited our emergency department?
I did.
Could you tell us the impressions you felt?
The initial impression was very favorable. Everything seemed to work nice, everything was nice and clean.
Yeah.
So, yes.
Have you noted something similar or something different from the departments you have visited throughout your career in the whole world?
Most departments are somewhat similar. The idea, people come in and they get sorted and sent into different areas. The biggest differences obviously would be in comparing them to, say, something in Vietnam or wherever where you have big, huge wards. But no, it looked very, very good, it looked very professional, and it was obvious that someone put some thought into it. I liked what I saw.
You mentioned you've been in Holland with the purpose to teach them.
Correct.
Yeah. How did that happen? And how was all the process happening there in Holland?
Because I have an interest in international emergency medicine and EMS, I know a lot of the people who do this and belong to different sections and organizations. And what happened was the Dutch decided that they wanted to make emergency medicine a specialty, and 4 hospitals began a training program in the year 2000 or so. One of them in Amsterdam, the OLVG, decided to jumpstart things by hiring somebody from a country where emergency medicine was an established specialty, rather than, because the person who found it was actually a surgeon, but he recognized that as a surgeon he didn't, he had limited experience, and his colleague, she was an internist in the same. So Dr. Mike Berg was the first American to go there, and they liked the experience, and then when he left, they hired me for 2 years.
All right. Could you describe 3 personal qualities for a person who wants to be an emergency physician?
They should be very quick to make decisions. They almost should have a short attention span. People that like to think on problems for a long time are usually good internal medicine doctors, but we have to make decisions with incomplete information. They have to be very people-oriented because we interact a lot with people, more so than many other specialties. So they have to have a good sense of humor and patience, otherwise they'll never get through it. And they have to have a little bit of thick skin.
What do you mean by that? Thick skin is like character?
Well, the ability to tolerate a certain degree of abuse and not let it get to you, not take offense at it.
Do you have any, in Lithuania, emergency medicine is just beginning its baby steps. Could you wish something for young physicians and their colleagues in in Lithuania for their future.
Absolutely. Lots of good luck. And I don't mean that in a bad way, but it will be hard work. And hopefully they can mold it so that it works for them, for your country, and for your patients.
All right. Thank you very much.
You're welcome.